Good afternoon and welcome to today's OR Today webinar. Today we are joined by Robert Dybec, OR Nurse Manager at NYU Long Island Hospital in New York and consultant to Ruhof. He has over 40 years experience in the surgical setting and has been a consultant for several companies providing education to nurses and technicians both nationally and internationally on a variety of topics. OR Today would like to thank our sponsor, Ruhof. Ruhof is an innovator and leading manufacturer, well renowned for offering reliable solutions and individualized service to help you meet and exceed your decontamination and materials management challenges. Ruhof not only provides the most effective decontamination products on the market, they also allow healthcare professionals to verify effectiveness with their line of cleaning verification products. So for more information, please visit ruhof.com. As usual, today's webinar is eligible for one continuing education hour from the California Board of Registered Nurses. You can obtain your certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1C certificate, and you'll be able to download the certificate directly from your computer once the survey is submitted. This webinar is also eligible for one contact hour from the CBSPD, so you will also be able to download that certificate once you've submitted the survey. If you have any questions, you can reach us at webinar@mdpublishing.com. Okay, today, let's kick off today's webinar by giving away one of our OR Today Live lunch call bags to the attendee that can tell me the answer to the following trivia question. January is National Soup Month. What region, not state, of the US is typically known for its clam chowder? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. We will have a Q&A session at the end of the presentation, so please submit any questions anytime using the questions feature on your webinar dashboard. As I mentioned earlier, our presenter today is Robert Dybec. So Robert, you may begin whenever you're ready.
Thank you, Linda. Thank you very much. Can you hear me okay?
Yes, we can.
I want to make sure my audio is working. Thank you very much. Well, good afternoon, everybody. Welcome to this OR Today webinar entitled The Life Cycle of a Surgical Instrument, Purchase, Use, Reprocessing, Replacement. My name is Robert Dybec, and I will be your presenter today. I first want to thank, the slides are not changing. Hold on one second. There we go. I first want to thank OR Today for the opportunity to present once again to all of my nursing colleagues and healthcare colleagues out there. This is my third webinar with them, and a special thanks to the Ruhof Corporation for their sponsorship of this educational activity. Let me start by giving you some information on my background. As Linda said, I am currently the OR Nurse Manager at NYU Long Island Hospital on Long Island in New York, which is part of the NYU system, where I oversee 5 surgical specialties. And I am also a consultant to the Ruhof Corporation as an educator for not only Ruhof staff, but on their behalf at national nursing meetings, such as AORN, SGNA, and other professional organizations like the Central Sterile Processing meeting. So let's take a look at our objectives for today. Well, we're going to discuss instrument selection for purchase and initial sterilization. We'll describe the use, reprocessing, and reuse of surgical instruments. We'll identify methods for testing instrumentation for cleanliness, and we'll address the end of life of a surgical instrument. So here's the instrument life of a life cycle of an instrument that I created. I'm going to make this larger so you can see it a little better. So this diagram and we're going to address literally every box on this diagram. So for surgical instrumentation starts with the purchase of surgical instruments. You know, your selection, things you have to consider, cost, things you should look out for. Now, after the purchase is received, it'll be sent to Central Sterile for inspection, for cleaning, assembling, sterilizing, and also tracking. And we will talk a little more about tracking along the cycle. After the instrument tray is sterile, it will be transported to the OR. In the OR, they will receive and track the instruments, store them, get ready for use. The tray can be selected and used for surgery. And in the operating room, before the procedure starts, the instruments should be inspected again for function and irregularities. as well as for the completeness of the tray. Look for any missing or extra or incorrect instruments. Intraoperatively, instruments need to be wiped down with clean water by the surgical tech or the RN scrub. And immediately after the procedure, we'll talk about the postoperative point of use cleaning and treatment with enzymatic solutions. From that point, the treated and soiled instruments will be transported to the central sterile processing department for instrument reprocessing. The trays will be cleaned, inspected, assembled, counted, and re-sterilized. And if the trays meet all parameters for inspection and sterilization, they will be tracked and transported back to the OR for reuse. If any instruments fail inspection, they will be sent out for repair or replacement. So at the beginning of the cycle, we will discuss the purchasing of surgical instruments. Now, some of you on this webinar may actually be involved with instrument purchases. Now, we all want to try and get the best price, but when it comes to surgical instruments, many times you get what you pay for. So some of the things you need to be aware of are not only just price, but selection. What company are you purchasing these instruments from? What is the reputation of this company? Are they well known? Are you buying from a distributor or direct from the manufacturer? For example, are you buying instruments from a well-known company that has been manufacturing surgical instruments for many, many years, such as some of those in Germany? Or are you purchasing and getting a great price from a dealer or distributor or even a manufacturer that's in a country that's not well known for producing quality surgical instrumentation? And also, what kind of guarantees are they going to put on their product? And above all, what is the quality of the instrumentation that you're going to be purchasing? So let's delve into the quality of surgical instruments. All surgical instruments are made of some sort of stainless steel. Now, I found it very interesting as I did some research about stainless steel used in surgical instruments. The name stainless steel is an American name. In Europe, stainless steel is called inox, I-N-O-X. Stainless steel only denotes steel that is corrosion and rust resistant, but stainless steel items, such as surgical instruments, can actually stain, so they're not stainless. Now, you may notice in your cutlery drawer at home that some of your utensils, your knives, your forks, your spoons, even after coming out of the washer, will have some sort of water stains on them. Stainless steel is actually a mixture of metals. It's a type of alchemy, if you will, all playing different roles in the final alloy. So the metals found in steel are pure iron, which in and of itself is highly corrosive and soft and will rust very easily. Think of any cast iron pots or pans that you have at home that must be treated to prevent rusting. But when combined with other metals, the iron becomes one of the most commonly used industrial materials. So carbon is added to iron to give it its hardness and ductility. Ductility is what affords the steel the ability to stretch under tensile strength. That's why we see on our needle holders or our clamps, they have the ability to kind of bend and not break when we clamp them down tight. Chromium is added to iron, which adds corrosion resistance. Nickel, magnesium, silicon, molybdenum, and sulfur are residual elements and may be present in the composition. So the actual degree to which steel becomes stainless is determined by all of these metals. Most stainless steel used in surgical instruments is called 420 stainless steel. It contains carbon, but is basically 70 to 80% iron. There's a thin layer that coats the stainless steel instrument, which is only about 30 microns thick, very, very thin, and much more fragile and easily damaged than many realize. This thin coating is the only thing that protects the steel underneath from deteriorating and corroding. Once that top layer is compromised, free iron could be released on the surface of the material, which starts the corrosion process. So what about surgical steel? Well, what is surgical steel? Surgical steel is a variety of stainless steel that is used in biomedical applications, sometimes referred to as surgical stainless. But the term surgical steel has no formal definition of what it consists of. Stainless steel varieties with the greatest levels of corrosion resistance are those designated for biomedical use because they will resist highly corrosive environments such as blood, body fluids, salt solutions, cleaning solutions, and sterilization methods. Here's a photo just showing some examples of surgical instruments where that outer layer has kind of broken down and corrosion has started. Rust is visible and the instrument itself has been compromised. And these look very different than the pristine instruments we see when we first purchase them, like this. So after the purchase is complete and all the instruments are received, they are sent to Central Sterile, where Central Sterile will receive them. At that point, they will inspect all the instruments and they will assign a tracking number to the tray being created. They'll clean the instruments per the manufacturer's IFUs, then create a count sheet for the instrument tray. They will assemble them, put them on stringers, and they will sterilize the tray and wrap or put them in canisters. This initial processing clearly is easier on the technician, as it does not involve any blood or other soil on the instruments that would need to be cleaned off. So the previous slide mentioned how the initial receipt of the instruments by Central Sterile was given a tracking barcode. So tracking is a very important part of following your instrument trays, and it has many different purposes and benefits. My hospital uses it, I'm not sure, but I think many other large hospitals with large central sterile departments are probably using tracking now. The benefits of tracking are numerous. So after assigning a barcode, which can be scanned, a tray can be followed along the cycle. Tracking can increase operational efficiencies, can be used for inventory management, for maintenance of instruments, locating trays in the cycle to where they are. I know for me personally, as a OR nurse manager, I'm constantly keeping track of where trays are for upcoming surgeries and using the tracking system, which will let me know exactly where they are. So if you look at the slide, on the initial receipt, the tray will be assigned the barcode by Central Sterile Processing, which can tell you also at any point in the system where it is. In Central Sterile, is it in their decon area, their prep and pack area? Is it being sterilized? It's in the sterilizer. Is it out of the sterilizer and cooling? Has it been dispatched to the OR? Did the OR receive it? And at all these points, the barcode is being scanned. Now, in the OR, we scan it into our nurse's record of operation, directly into Epic. So we know exactly which trays are being used on which patients. And then in Central Sterile, they'll track it when it's received back from the OR for reprocessing after use. So tracking and the ability to track your surgical instruments, as stated, has many, many benefits. So at this point, the new tray has been sterilized, counted, it's ready to go, and Central Sterile is going to shoot it off to the operating room. Now, when the operating room receives the trays, they will be scanned in once again for the tracking system and placed into storage and ready to use for surgery. Canisterization, or placing instruments in canisters, is a better method than wrapping, as wrapping from rough handling can result in holes in wrappers and compromise sterility. I don't know if many of the hospitals have this issue. In my hospital, we have issues with a lot of loaner trays coming in, orthopedic loaner trays, which don't have canisters and sometimes are extremely, extremely heavy. And rough handling can cause, holes in wrappers, which then compromises sterility. And now you have to see about getting another tray. So it's a time constraint. It's a sterility issue. So canisterization is definitely preferred over wrappers, in my opinion, anyway. So preoperatively, when we're setting up for a case, the RN scrub, or the surgical tech, will first look for and check the indicator in the tray, which would show that the instruments have been subject to the proper sterilization method. Further inspection would look for irregularities on the instruments, such as staining, rust, corrosion, pitting, damage, or foreign materials. Then an instrument count will be performed with the circulator and scrub to make sure not only that all of the instruments are there, but that they are the correct instruments. Checking the instruments for proper functionality may also be done by the scrub. The circulating nurse will scan the barcode of each instrument tray into the nurse's record of operation. Again, for my hospital, we use the Epic system, and this information will be populated directly into the patient's chart. During the surgery, if any instruments are deemed to be compromised, then the scrub will put them off to the side so that they can be tagged before sending to Central Sterile Supply. And this includes things such as scissors that the surgeon may feel are not sharp enough and may need to be sharpened, or any other surgical instrument that may be having issues functioning. Now, one of the most important roles of the scrub is to rinse and wipe down instruments intraoperatively to remove blood and tissue. AORN recommended practices state that sterile water should be used intraoperatively to keep surgical instruments clean. At the end of the procedure, the scrub should wipe down all instruments with visible soil and remove as much as possible. This is actually the beginning of the reprocessing cycle. So the reprocessing cycle starts in the operating room again with the wiping down and then the application of enzymatic solutions, typically a foam spray or a humectant gel. These photos here are early photos from my operating room. We began spraying instruments with a Prepzyme foam. Shortly after that, we moved away from the foam and started using a humectant gel, which has properties of keeping instruments moist for up to 72 hours. And this was an important thing for us as our central sterile department was not a 24/7 unit. And there was a potential for instruments to sit unprocessed for up to 72 hours, especially over the weekend. And so the method of wiping down instruments and applying an enzymatic solution to them is known as point of use cleaning. Again, this is the beginning of the reprocessing phase. It happens in the operating room. If you look at the pictures here, you can actually see some of the blood on these instruments starting to come through on the foam. The enzyme in the humectant gel will break down the process of the bioburden left on the surgical instruments from the procedure. Again, this is extremely important because if bioburden is left to dry on instruments, it may lead to the formation of biofilm. At that point, the OR will send these soiled and treated instruments down to central sterile for them to take over for reprocessing. So just want to backtrack and do a quick review about what's left on our surgical instruments. So let's talk about bioburden. What is bioburden? So according to Ansi and Amy, bioburden is defined as a population of viable microorganisms on a device or a surface. Bioburden can be the result of contamination by blood, tissue, feces, mucus, and can be found on our medical and surgical equipment and endoscopes after they have been used on patients in both surgical and procedural areas, as well as the surfaces in these surgical and procedural areas, our OR tables, our back tables, our mayos, kick buckets, and things like that. This gross contamination of bioburden, if left on surfaces or even in scopes or cannulated instruments for too long, may allow for the formation of biofilm. So what is biofilm? Okay, so biofilm is defined as an aggregate of microbes in which the cells adhere to each other and or to a surface, producing a distinct architecture. Biofilm can reform as the result of bioburden not being removed quickly and efficiently and allowed to start drying. Again, why we're using these foam and humectant gels in the OR, keep them from drying out. So these microbes will adhere to a surface and begin to build a matrix that holds the biofilm community together. The microbes will then encase themselves under a protective polysaccharide layer, and nutrients will start to feed the biofilm, this little biofilm community, and allow them to proliferate. So again, what can we do in the OR to reduce the risk of biofilm development? Well, we said that biofilm can form as the result of bioburden not being removed quickly and efficiently and allowed to start drying. This is why we have policies and procedures in place for the intraoperative care of surgical instruments, wiping instruments intraoperatively to remove gross contamination, post-procedure cleaning of gross contamination, wiping and flushing, and of course the application of an enzymatic solution or gel to keep the instruments from drying out before being received in central sterile for reprocessing. So there are 5 distinct stages of biofilm development. So stage 1 is the initial attachment. That's where the organisms initially adhere to a surface. Stage 2 is called irreversible attachment. That's where the organisms start to protect themselves under a polysaccharide protective layer. Stages 3 and 4 are the first and second stage of maturation. That's where the biofilm continues to grow and mature. And stage 5 is a very interesting stage. It's called the dispersion stage. That's where the biofilm actually opens up to release more organisms that will spread and start colonizing new surfaces. So it's like a process where the biofilm will continue to grow and develop and then start colonizing new areas. When I do presentations on bioburden and biofilm, it always comes to mind, living here in the Northeast, how a certain warm day in the spring will allow termites from the ground to come flying out with wings to look to colonize new areas. Same thing with the biofilm. It's going to open up in that dispersion phase. It's going to release more pathogens into the environment to start colonizing new areas. So the bacteria that's growing inside a biofilm is over 1,000 times more resistant to antibiotics than the same bacteria not growing in a biofilm. Now this slide depicts the protective nature of that biofilm and how that outer polysaccharide layer will not permit antibiotics to penetrate and harm the pathogens that are growing inside. Bacterial biofilms are usually pathogenic and can cause persistent and chronic bacterial infections. Among all microbial and chronic infections, to include hospital-acquired infections, 65 and 80% respectively are associated with biofilm formation. These infections are a significant source of morbidity and mortality as the second most prevalent cause of death globally. According to the World Health Organization global estimates, they say that 7 to 10% of patients admitted to hospitals acquire at least one type of healthcare acquired infection. And of these patients, 10% will die. In the United States alone, approximately 1.7 million patients develop HAIs annually, with a prevalence rate of 4.5%, causing more than 90,000 deaths each year. Here's an important takeaway. Surgical site infections contributed to the highest proportion of HAIs in the US, followed by catheter-associated UTIs. So we mentioned earlier about surgical site infections being the most prevalent. Surgical site infections have been associated with pathogenic biofilms, and they can present sometimes 30 to 90 days post-surgery, and it is the most common post-operative complication. SSIs develop in an estimated 2.6 of all patients who have surgery and account for 20% of all hospital-acquired infections. Biofilm-associated SSIs are extremely difficult to treat with conventional antibiotics, again, due to the tolerance mechanisms of the multi-drug resistant bacteria in the biofilm form under that polysaccharide protective layer. Some of the chronic non-healing wounds that we see in the hospitals are a result of biofilm, which even after sharp debridement, washouts, antibiotic therapy, these wounds are still not healing. So think of the cycles of, again, biofilm development. Unless all of the biofilm colonies are eradicated, then they may continue to repopulate the wound when they open up in the dispersion phase. It's a chronic cycle with these chronic non-healing wounds. So regardless of the cause or type of infections, hospital-acquired infections, SSIs can have several consequences, including prolonged length of stay, required for repeat or secondary surgeries, a decreased quality of life, increased costs, litigation, and even death on some patients. Hospital-acquired infections in U.S. hospitals have direct yearly medical costs of at least $28.4 billion. They also account for an added $12.4 billion in costs to society from early deaths, loss of productivity, as well as monies associated with medical legal claims. So let's get back to the cycle. We diverted a little bit there for a second, but so now the OR is going to transport to central sterile. The soiled, wiped, treated instruments are going to central sterile supply. So in central sterile processing, they will receive the instruments from the operating room, and they will be tracked, cleaned, inspected, assembled, counted, and sterilized. Sounds simple, right? But this is one of the most critical steps in getting our surgical instruments ready for use again. I would suggest that if possible, if you're in the OR, you should send your OR staff, somebody in the OR, to the central sterile processing department for one day to see what they do to actually get our instruments properly cleaned and ready for surgery. I know that our central sterile technicians, when they're brought on initially, they will take a tour of the OR to see what's going on. We have in the past in my hospital sent new OR staff down to Central Sterile to see what they do down there. We are a team, and I think it's good for an understanding to see what each department is doing and how we rely on each other, how effective we can work together. So the primary goal of disinfection and sterilization in central sterile processing is patient safety, to provide instruments for use in patient surgeries and procedures that are cleaned appropriately, and to improve patient outcomes and reduce rates of healthcare associated infections. So when you think about the thousands of types of surgical instruments that Central Sterile must deal with on a weekly basis, things such as our standard instruments, clamps and scissors, delicate microsurgery and neurosurgery instruments, orthopedic instruments, cannulated instruments that require cleaning inside channels, instruments that have been subjected to all sorts of soil and bioburden, instruments that need to be disassembled for proper cleaning. And with all of these, the objective remains the same from Central Sterile: the removal of foreign material, soil, blood, organic matter from our surgical instruments. The purpose is because organic matter can interfere with the effectiveness of disinfection and sterilization. Dried organic material increases the difficulty in the removal process and ultimately prevents disinfection and sterilization techniques from occurring. So the numerous considerations in the cleaning process and the countless steps that must be taken to ensure clean instruments, it's mind-boggling. Different manufacturers with different IFUs for cleaning their instruments requiring different aspects of manual cleaning, water temperature, chemicals used in cleaning. I mean, look at this slide, which has the CDC guidelines for disinfection and sterilization in healthcare facilities from 2008, showing some of the things that central sterile technicians must be aware of. Cleaning with water and detergent or water and enzymatic cleaners prior to high-level disinfection and sterilization. The cleaning solution is critical. The water temperature and quality of the water is critical. You want to use neutral or near neutral pH cleaning chemicals. Common cleaners contain enzymes used to assist in removing organic matter. Protease cleaners attack proteins. Lipase cleaners are effective on fats. And you have to follow the manufacturer guidelines and rinse thoroughly with all of these chemicals. There's just so much knowledge and so many different parameters that these central sterile technicians must follow to be effective. And to continue, the central sterile technician must inspect for breaks in integrity that would impair cleaning, impair disinfection and sterilization, looking for damaged instruments, engraved instruments, difficult to clean areas. They must perform manual cleaning or mechanical cleaning based on the manufacturer's IFUs. Some of the essential components of manual cleaning include friction, rubbing, scrubbing with a brush. Scopes and cannulated instruments can especially be a challenge to get inside of and around crevices. You think think of your cannulated reamers in orthopedics. You have the inner cannula, you have the outside area which could contain bone fragments and bone cement, two things that are very, very difficult to clean. I've seen so many trays opened up for the start of a case where the scrub nurse or tech will detect a piece of a bone stuck in a cannulated reamer or something like that, at which point, we cannot use the tray. So with everything the central sterile technician must know and do to effectively clean our surgical instruments, let's just give a shout out to them. They really truly are an integral part of the perioperative team, ensuring that our instruments are cleaned properly and sterilized properly. It's a lot more than just throwing them in a washer, stringing them up again and sending them back to the OR. And as I said, they are a key player in patient safety, good surgical outcomes, and reducing the risk of infections. So let's now discuss methods for testing for cleanliness. Assessing successful cleaning processes of surfaces, devices, instruments in the healthcare environment can be supported by implementing contamination monitoring methods, such as direct practice observation, swab cultures, agar slide cultures, ATP bioluminescence tests, and protein tests. Now, the AAMI standards dictate that any test methods used to monitor cleaning effectiveness should be accurate, objective, replicable, rapid, simple, and quantitative. So visual inspection, that can help when gross contamination is visible, but it is clearly not a reliable measure of any level of cleanliness. Visual inspection cannot detect biofilm and cannot detect unseen bioburden. Additional verification is necessary to ensure optimum patient safety, and there are multiple verification methods that can be used as an adjunct to assessing cleaning efficacy. So direct visual observation, in Central Sterile, they have these large magnifying glasses. They have borescopes and other things that they can use to directly observe bioburden left over. But again, if an instrument looks clean, doesn't always necessarily mean that it is clean. So using laboratory cultures to check for residual bioburden or cleanliness, although it's an easy test and will provide literally specific data about which pathogens may be growing, it has its time constraints. It's not a quick and efficient test, as we can be waiting for several days for results to come back. So if you want to test your surgical instruments after the cleaning process before sterilization and you send out a culture, do you have 2 days to wait to start sterilizing those instruments to see if they've been cleaned effectively? I think in a busy hospital, in a busy OR, we don't have time to be waiting for instruments to grow cultures. So again, it's not a quick and efficient test. So although some difficulties have been encountered in utilizing agar slide cultures on surfaces that are not flat and broad, the technique generally will provide an easy method for quantifying viable surface contamination, but similar to laboratory swab cultures, it's necessary to wait for the results. You're going to swab these items, you're going to put it in an agar dish, a Petri dish, and it's not a time-efficient method while you're waiting for things to grow to see if something is on your surgical instruments. So ATP testing has become extremely popular over the past decades. All living cells will use adenosine triphosphate as the fuel to drive biological reactions for cell function. It literally is the energy molecule of all cells, first discovered in 1929. Now, because of its ability to provide real-time results, ATP testing methods were developed and have been widely used since the 1980s in the food industry to monitor the hygienic status of food production lines and verify the efficacy of cleaning procedures. And now it is widely used in healthcare clinical settings. So the presence of ATP on medical devices, instruments, or surfaces may be an indicator of residual contamination. Modern bioluminescence tests are based on the reaction of luciferase extracted from fireflies with its substrate luciferin, known as a luciferin-luciferase reaction, which generates light. Now, the amount of light emitted in this reaction is directly proportional to the amount of ATP present in the sample. The ATP bioluminescence testing for cleanliness is based on the measurement, again, of levels of ATP. It will detect organic matter, but will not be able to detect pathogens that cannot produce ATP, such as viruses. This method is carried out by swabbing a surface, inserting the sample into an ATP test sleeve, which contains the luciferin. That reacts to oxygen, and then it's placed into a handheld ATP luminometer. When it's placed into this device, light will be generated from the reaction, and the luminometer will measure the amount of light and give you a quantitative result of the amount of soil left on a particular item. So the higher the number, for instance, if you have a surgical instrument that you want to test to make sure it was cleaned properly, you can get a number which is acceptable or not acceptable. If the number is too high and not acceptable, all that means is that item, that instrument, should be cleaned again and tested again before sending out for final sterilization or high-level disinfection. So some of the benefits of ATP testing, again, it's a confirmation of the cleanliness of surfaces, of instruments, endoscopes, and even the environment. These devices can be used to test surgical environments in the operating room, overhead lights, OR tables, patient waiting areas, procedural rooms. It will reduce the risk of cross-contamination between patients because you will be able to determine if items are truly, truly clean. It has the ability to track and monitor cleaning practices. So the devices can actually be used to program certain things. So an example would be, say in the GI suite, they may want to label or program it for endoscope number 1, 2, 3, 4, and 5. And for some reason, every time they clean and test the scopes, number 5 seems to be having an issue. Well, that may mean that number 5 scope should go out for repair or testing to see if there's any compromise going on that's they're not aware of. Or what about cleaning practices? If in Central Sterile, they're going to check the cleaning practices of John, Jane, and Joe, and for some reason, Joe's having more higher levels of ATP when he does instruments, maybe that could include he needs to be retrained. Is he using the correct chemicals, the correct temperature, the right ratio of chemicals to water? So you can look for cleaning practices. You do get a quantitative assessment. There's going to be a digital readout of the level and number of ATP present. This can be used in documentation. If you have the Joint Commission come in and they kind of want to know how are you testing for cleanliness, you can actually generate and run reports from this program to show them what you're tracking and the results of the tracking. But the main thing with ATP testing, it's a quick and easy test. You get results in as little as 15 seconds. So it's a quick and easy way to determine if your instruments are actually have been cleaned properly, an effective cleaning. So protein tests have also gained popularity recently, and like ATP testing, they've become easier to do with quick results, but also they will only detect protein as a factor in residual contamination. So they're looking for protein, they're testing for protein. The protein may contain something that's bad for your patient. It may have pathogens in there, but we don't know that for sure. All it's giving us is a general assessment of cleanliness. So at the conclusion of the cycle, Central Sterile will determine if the instruments are ready for use or if they need to be replaced or repaired. If they need to be replaced or repaired, items will be sent out or removed from the tray. A clean and sterile tray will be transported back to the operating room for continued use in the next surgery. So Central Sterile technicians on the front line, they face enormous challenges in monitoring the high volume of instruments they see and checking for blemishes, for corrosion, for anything that could impact patient safety. So how do you really know when an instrument is at its end of life? Well, indicators would be things such as rust on instruments that cannot be resolved, decreased functionality, corrosion of instruments, permanent stains that cannot be removed by stain removers, cracks in instruments, decreased functionality, and basically instruments that have outlived their useful life. They're no longer under guarantee or warranty, and basically instruments that can no longer safely be used in surgery. So just some important takeaways I want you to remember from this presentation. The cleaning of instruments, the reprocessing phase it begins intraoperatively in the operating room and at the point of use. The wiping down of instruments, the use of enzymatic gels or humectants to keep instruments moist to start the breakdown of the bioburden. The easier it is for Central to clean these things, the better it's going to be for the instruments. To receive an instrument in Central Sterile that's got dried, hard blood on it takes much longer to clean than an instrument that's got, maybe blood on it, but it's moist. It started the breakdown process. So it makes the job easier for Central, and it's also better for the instrumentation. Effectively cleaned instruments will reduce the risk of infection and also increase the life of an instrument. It's like your car. You want to treat your car well. You're gonna give it an oil change. You're gonna wash it regularly and keep it well. If you keep things well, they will last a long time. Don't forget that not all surgical instruments are created equal. I've seen trays of instruments that have clamps from different manufacturers, and they look different, they act different. Some of them are starting to corrode or show signs of wear and tear, whereas others are not. And also testing methods for cleanliness. They've definitely improved. They've expanded to different areas, and they are quicker than ever. So just to summarize, we discussed instrumentation selection for purchase and initial sterilization. We described the use, reprocessing, the critical steps of reprocessing, and the reuse of a surgical instrument. We identified methods for testing instrumentation for cleanliness, and we addressed the end of the life of a surgical instrument. So thank you everyone who tuned in. I appreciate your attendance. I hope you enjoyed it. And now we'll open up the floor to some questions and answers. And Linda, I'll send it back to you.
Perfect. Thank you so much, Robert. We've had a few questions come in. The first one is, how can my OR staff be sure that instruments are sterile before using them on a patient?
All right, well, so you're opening an instrument tray and your staff's wondering, how do I know these are sterile? Well, there's several ways. Clearly, there's going to be, or needs to be, an indicator inside the tray that needs to have changed to show that they've been subjected to the proper temperature and steam for an autoclave. You need to look at the tray lids to make sure that they're intact. Excuse me, sipping water. So the tray lids need to be intact. The plastic clamps on the tray lid need to be intact. If you have trays clearly with the blue paper on top, you're going to check for holes to make sure that the blue paper is intact. And you're going to look at the load numbers, the date, see how long they've been around, making sure that's also why Central tracks the load numbers and dates in case they have sterilization issues. They will notify the OR of potential load numbers that have compromised, and we'll remove those from the shelf. And inspect, preoperatively the scrub, RN scrub, or the surgical tech can look at the instruments, look inside the tray to see, is there any hidden foreign matter, bone and cannulated instruments. I mean, in my many years, it's incredible the things I've seen when you open an instrument tray, to everything from a ballpoint pen to a hair clip, materials that we really don't even know what it is. But then there's clean instruments that haven't been cleaned properly, a lot of bone fragments and bone cement left on instruments. So inspection. So you really kind of have like trust and faith that it is sterile. It's met the parameters. Central did their best. They cleaned it the best. And if there's any questions about sterility, then you just escalate that, and better to be safe.
Perfect. Actually, following on from that, just one's popped up. There's too many elective cases on top of add-on cases and not enough trays to use. What are your thoughts on this?
Well, buy more trays. that would be the easy answer. But again, therein lies the problem, because we do have a central sterile department that has a tough time keeping up with the workload. They're processing, I think at last count they were telling me, over 11,000 trays a month, and each service has their own priorities. I cover 5 services, and that's why the tracking system is so important, to keep track of where are my trays in the system. I'll come in one morning and I cover urology, and I see on the schedule we have 8 transurethral resections of bladder tumors, which means I need resectoscope trays. How many resectoscope trays do I have on the shelf? Well, if I only have 3 or 4, I'm going to go right to the tracking system and see where they are. Are they in sterilization? Are they cooling? Are they not available? Am I going to have them by the end of the day when I need them for the later cases? The bigger answer is, if you don't have enough trays, you run into this problem. There's prioritizing of trays, where everybody's stepping away from immediate use steam sterilization because we're getting dinged for that. And the other problem is with holes in wrappers. How many times have I had holes in wrappers where now I can't use that tray? So there is no easy answer. If you have enough trays, if you have a central sterile department, if you're not that busy, you'll be able to keep up with the workload. But it's a challenge. It's literally every day a challenge. Myself and my assistant nurse manager, this is part of our job, literally every day, making sure that we're going to not delay surgery, not cancel surgery because we don't have enough or the proper instrumentation.
Okay, another tray question here. Is there staining or if there is staining or foreign looking material on instruments in a tray, isn't it sterile and okay to use because it's been sterilized?
Well, that depends on who you ask. I've had surgeons say, it's okay, it's been sterilized. I don't care that the central sterile technician dropped their big pen in the tray. It was sterilized. So the answer is no. Anything foreign cannot be considered sterile. It might be, but we don't know. You're not going to take a chance if you open a tray and there's something that's not right about it, that there's something foreign on there, that there's staining, that there's rust, anything you suspect. I would want, if it was me being operated on or a family member, I would want that tray replaced until you got one that's acceptable. And our surgical techs in my hospital, they're very, very astute at looking for things and finding things and making sure that the trays and instruments are pretty much pristine and perfect and ready to go. So the answer is no, it's not sterile. Shouldn't be considered sterile. Might be, but shouldn't be considered sterile.
Okay. So would you recommend testing instruments before using them in the OR?
So the answer to that is no, really. You do have to have faith and trust that the central sterile has processed them properly. The problem with testing in the OR is you may open a tray and then say you're going to want to check it. So you're going to take the ATP swab or some other testing method and test an instrument. The problem is as soon as you touch an instrument with the swab to test, it's no longer considered sterile. You've actually contaminated it. So it makes no sense to test instruments in the OR before use. The testing for protein tests for ATP, that's a test of the effectiveness of cleaning, your cleaning practices. So after instruments are washed and ready to be reassembled, that's when central sterile can do the testing to see if they've been cleaned effectively. And if they haven't been cleaned effectively, then they'll be re-cleaned and retested before sterilizing. So not in the OR though.
Okay, perfect. And another question here is, with many devices, IFU indicate to clean process immediately after use. So I'm wondering how it's okay to wait up to 72 hours. Has this deviation been addressed to the device manufacturer and or the product manufacturer?
Sometimes it has. Again, recommendations from manufacturers, like something like that, how can they dictate, how busy your OR is, what your central sterile is capable of doing. I've not seen anything like that where it says it should be, I mean, they can say it should be processed as soon as possible after use, but to say that it should be sent down and made a priority, we send down a lot of priorities, but that's for trays that are going to be needed again, not because this particular item or particular tray, the manufacturers of IFUs say, do it as soon as possible. In the event that you can't do it as soon as possible, even better, or should I say more important, the need to wipe it down, flush it out if it's got an interlumen or a cannula, get that enzyme spray and humectant on there to keep it from drying out. But to actually recommend that's kind of absurd if you ask me, that it should be processed immediately. It's bad enough that many of these manufacturers are dictating many times which chemicals should be used. They're validating and verifying certain chemicals that can be used on instruments, and their manual cleaning processes, what mechanical washers you should or shouldn't use. It puts a huge burden on central sterile processing, and I know my central sterile processing, they are sticklers for IFUs. Everything from what an instrument can be wrapped in. Is it going to be peel packed? Can it go in a little, brown mud box or something like that? And they follow to a T, because if they don't, and then something happens, it's going to get back to them. Well, did you follow the IFUs? So I don't know if that answered that, but that's I'd be interested to know. Shoot me an email afterwards. What is that instrument or equipment that requires it to be processed immediately?
Okay, that's great. So what do you suggest for sterilizers in dental offices that have new gaskets, are working properly, spore tests pass, but packs and cassettes are still wet when the cycle, including dry time, is completed?
Well, that sounds like, again, I'm not a central sterile technician, but we have had issues with wet trays coming up. We'll open up a tray and there'll be water on the bottom. And what central sterile tells me is that many times it's just a not a long enough of a cooling time. Could be a problem. I mean, the autoclave's checking out, like you said, the autoclave's checking out, but there's still water in there. So has it cooled long enough? And the instrument tray or whatever it's in, is that canister okay? You know, we have flash canisters that we use when we have to, when there's no other choice, and those get tested and maintained regularly to make sure that that their gaskets and their devices for allowing steam to enter and exit are working properly. So yeah, anytime we open a tray and it's got moisture in it, we take it right off the field. We don't consider it sterile. So here's the other thought, because I also cover oral, maxillofacial, and dental in my hospital. When you realize what dentists are doing in their offices, you know, it's a little more, oh, we're in the mouth, you know, it's not as critical. Well, if it's my mouth, it's critical. But in the past days, in the old days, these guys were wiping stuff down and washing them off the best they could. But now they're following the parameters of what's required by, you know, the hospitals and ANSI and AMI and OSHA and all these other regulatory agencies. So you got to follow that. But I don't know what you're doing in the dental area, but if instruments are wet in the OR, tray's wet, you know, we immediately take them off. And then we let Central Sterile know, because they'll backtrack the load to see if there's any other instruments that have been affected, or maybe it was the autoclave.
Okay, thank you. So what do you think of trays versus peel packs?
Well, peel packs are, for my experience, the peel packs have gone by the wayside a little bit. I will tell you that I have one item where the manufacturer's IFUs specifically say that you need to put it in a peel pack. It's the navigation suction for the Trudy device, which, you know, I always complain to Central Sterile. I said, you know, why can't we put these in the little brown, we call them mud boxes? And they said, no, we can't. The manufacturer says we have to peel pack them. And I actually brought up the IFUs, and it says that, you know, peel packs have to be used for this particular item. For the most part, if it doesn't say it has to be used, much greater risk of, you know, puncturing the peel pack, you know, how's it handled? Is there something getting thrown on top of it? They can be compromised much more than putting them in even a single device, say it's a specialty scissor or something like that. We will put them in a small little brown box and wrap them separately, and there's much less chance of a hole in the wrapper for a single device like that. So there is definitely still a place for peel packs, but I think I've seen use go way down. We used to have a whole cart full of peel packs for like extra instruments, extra Mayo scissors, extra clamps, extra mosquitoes, and now everything's put in these little boxes because they can be. It's not the manufacturer saying that they can't be.
Okay, good. Okay, another question here is, when it comes to ATP testing of scopes, are the thresholds designated by a specific agency or guidance?
So the manufacturers of the ATP devices, they have parameters for what they consider to be an acceptable number for ATP. So like you can wash a scope, you can, and I know some testing devices, you can actually test the inner lumen, the working channel of endoscopes, to see how effective the cleaning process was in there. And if the number is below a certain, you don't have to get to 0 is what I'm saying, but if the number is, say, 200 or below, that's considered an acceptable range to proceed with sterilization or high-level disinfection. Anything above that number means that the item has more than acceptable number of ATP molecules on it and should be re-cleaned and retested before sending out for high-level disinfection. So scopes especially very difficult. I've done presentations on PRCP scopes and other scopes that are very difficult to clean and testing. And but ATP is a great method for that, because some devices can actually test the inner lumens, those inner channels, which, you know, you worry about, are they being cleaned properly?
Okay, super. We've got time for one more question here. Is, what's your input on IUSS?
Well, I can tell you my IUSS has a place, because there is going to be times where, you know, something's compromised. It's the only one you got. Surgeon can't do the case without it. So it has a place. We're actually getting a new autoclave in our LR, but we track our IUSS rates. we're trying to maintain 0 IUSS. We've never really gotten there. I think the lowest we've got in all the time we've been tracking is they call it's 2%, but it's 2% of the amount of surgeries we're doing, which are, you know, crazy amount of surgeries. You know, probably I think it's 40,000 surgeries in the course of a month. So our IUSS rate is very, very low, but it has a place. You know, you have to be able to flash. We call it flash. It's not flash anymore. You have to be able to IUSS, you know, certain items or even certain trays if it's compromised. And you know, what if you have a patient on the table and then all of a sudden you realize something's wrong with this tray and you don't have another tray? You have to be able to use IUSS. I don't think any hospital should get rid of a steam sterilizer in the OR because it does have a place. We've gotten our rate low because of increasing instrumentation and also by putting things in canisters. Canisters have removed a lot of the issues we had with, you know, holes in wrappers and especially that. You know, you'd hate to open a perfectly good tray and then somebody looks at the wrapper and you see a tiny little hole and now you can't use it. So canisterization and buying literally more instrumentation has helped us with that.
Perfect. Okay, before we wrap up, Robert, have you got any top tips you'd like to give everyone?
Well, just again, you know, the takeaway points that I said, you know, it's important to make sure that the instruments are getting wiped down intraoperatively. That's a recommendation. That's a recommended practice. Spraying the instrumentation with a humectant spray, an enzyme spray before sending it down to central. I will tell you that we were instrumental many years ago. We literally in every OR we have mounted on the wall a sprayer, which, you know, it can spray the instruments very quickly. It's, you know, like a power sprayer, and the staff love it because when you're doing an orthopedic case or a neuro case where you're opening 10, 20, sometimes 30 trays, which now have to be sprayed down, even if you don't use the tray, Central Sterile is requiring that all trays be sprayed. So to stand there with a little 32-ounce, you know, gun with you have to squeeze the handle. By the time you're done, you're going to require surgery for carpal tunnel. So in every OR we have a sprayer, and they spray the instruments. It's lowered our turnover time. We can get the instruments out quicker, put them on the cart, get them down to central, and then we can start cleaning the room. So that's probably one of the big things. And then the other things I mentioned, you know, keep inspecting your instruments, you know, intraoperatively. Look for things, look for issues. You know, we're all human. We may miss things. Central Sterile people may miss things. But if you see something that compromises an instrument, then, you know, escalate it, bring it to the attention of, you know, the circulating nurse or a manager or something like that. Do what's best for the patient. And again, you know, if you treat your surgical instruments right, they'll treat you right.
Perfect. Thank you so much, Robert, for your time today and for such a great presentation.
You're very welcome.
Thank you. Please visit Ruhof's website, ruhof.com, to learn more about the products they provide for the industry. As promised, the answer to today's trivia question is New England, so congratulations to our winner, Kimberly Jones. Now, just a quick reminder, you can attain your CE certificates by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your certificates, and you'll be able to download them directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Please visit ortodaywebinars.live for more details of all our upcoming webinars and, of course, complimentary registration. If you've missed any of our past webinars, including any by Ruhof, please visit ortoday.live to view our whole webinar archive. Thank you for your time today, and I hope you will enjoy the rest of your day.